Welcome to the deep dive.
Great to be here.
Today, we're sorting through this big stack of sources, research papers, clinical notes, patient guides, all focused on vascular health. And we're pulling out the essentials to build a roadmap, really.
Yeah.
A step-by-step guide for one specific, very important journey, preparing for and understanding an open vascular procedure for peripheral arterial disease.
Yeah, that's a condition we see a lot. Peripheral arterial disease, often just called PAD. It's basically where the arteries, usually in your legs, get narrowed or blocked.
Reducing blood flow.
Exactly. And that can cause pain, cramps, problems with healing, all sorts of issues. Now, sometimes lifestyle changes and medication are enough.
Right.
But when things are more serious or conservative management isn't working, an open surgical procedure might be the best way to fix the blockage and get that blood flowing properly again.
So our mission today is to use these sources, all this information, to guide you, the listener, through that whole process. Maybe you're facing this surgery or know someone who is, or maybe you're just interested. We want to break it down, step by step. What you need to know, what to expect, how to navigate it all. It's really about feeling informed, isn't it? Less uncertain.
Absolutely. Feeling prepared makes a huge difference. We'll walk through the whole thing, starting way before the surgery, right through recovery and beyond. Think of it as your essential guide, based on what the experts are saying.
Okay, sounds good. Let's unpack this stack then and dive right into step one, what you can actually do to prepare well before that surgery date even arrives.
Right. And this preparation phase is, well, it's absolutely foundational. The sources really hammer this home. It starts way before the operation.
It's not just about the day itself.
Not at all. It's about getting your overall health in the best possible shape. It's about tackling those underlying conditions and risk factors that, contributed to the peripheral arterial disease in the first place. This phase, it's critical for setting you up for a successful surgery and, just as importantly, a smoother recovery.
So you're addressing the bigger picture, the root causes.
Precisely. And the sources are pretty clear on the big targets here. Managing your cardiovascular risk factors, that's absolutely vital. And right at the top of that list, mentioned again and again, smoking.
Smoking. Okay, how big of a deal is it really?
Oh, it's huge. A major, major risk factor for peripheral arterial disease. The stuff in cigarette smoke, it directly harms the lining of your arteries. It speeds up that whole process of narrowing and hardening, atherosclerosis.
So quitting is key.
It's one of the most impactful things you can possibly do, not just for your arteries long-term, everywhere in your body, but specifically for healing after surgery. It reduces complications significantly. The sources strongly suggest quitting well before the procedure if possible.
Okay, so step one, seriously tackle smoking. What else falls under managing those heart and blood vessel risks?
Blood pressure control. That's another big one. High blood pressure, hypertension, it puts constant extra stress on your artery walls, contributes to damage over time.
Right.
Getting that blood pressure under control can really impact your overall blood flow, and the sources point out it can influence how well the surgery goes. There's even a specific mention that really intensive blood pressure control can lower the risk of future heart attacks or strokes in people who have both peripheral arterial disease and diabetes.
And cholesterol, I assume that's in the mix too.
Oh, absolutely. Cholesterol management is essential. Those fatty plaques that build up in the arteries, that's the core problem in peripheral arterial disease. So the sources recommend statin therapy. Those are the cholesterol-lowering medications for pretty much everyone with vascular disease. Keeping cholesterol levels down helps slow that plaque buildup.
Makes sense. So beyond those big three, smoking, blood pressure, cholesterol, what about medication someone might already be taking for other things?
That's a really critical point. Your medical team will absolutely focus on this. A thorough medication review is a standard part of the prep. The sources talk a lot about medications that prevent blood clots, things like antiplatelet therapies, aspirin, clopidogrel, drugs like that.
Which many people with heart or vascular issues are already on, right?
Exactly. They're often prescribed to lower the risk of heart attacks, stroke, or, clots causing problems in the limbs themselves. For example, one source mentions using a single antiplatelet drug for folks with aneurysms behind the knee, these bulges in the artery, to reduce the risk of major problems with the leg.
But wait, if you're going into surgery, isn't bleeding a concern with those drugs?
That's the tightrope walk. It's a very delicate balance. These medications are crucial for preventing dangerous clots, but yes, they absolutely increase the risk of bleeding during and after the operation.
So what happens?
So your surgical team, your doctors, they will meticulously review everything you're taking. Any antiplatelet drugs, any anticoagulants, sometimes called blood thinners, And they'll likely make adjustments. They might stop some medications temporarily or change the dose in the days or maybe even weeks leading up to the surgery.
And that's tailored to each person.
Completely tailored. It depends on your specific health, the exact type of surgery planned, your overall bleeding versus clotting risk. And this is crucial. You should never stop these medications on your own. Never. It has to be under the direct guidance of your medical team. The sources even mention that taking 2 types of antiplatelet drugs, what they call dual antiplatelet therapy, can increase bleeding during certain operations. It just underscores how carefully this needs managing.
Wow. Okay, so this whole preparation phase, it sounds less like a quick checklist and more like a full health tune-up before the main event.
That's a great way to put it. It really is, getting your whole system optimized. And lifestyle advice is woven into reinforcing things like regular exercise. Even gentle walking can improve circulation beforehand. And sticking to a healthy diet, obviously, supports overall heart and blood vessel health.
Okay, so we're working on getting healthier overall.
Yeah.
Meanwhile, how do the doctors get that really clear picture of the disease itself? Figure out exactly where the blockages are, how bad they are, before they plan the actual surgery.
Yes, the diagnostic side. That involves a range of tests, mostly non-invasive, meaning they don't involve needles or cutting. These tests are key for mapping things out.
What kind of tests?
Several common ones are mentioned. A really fundamental one is the ankle brachial pressure index, or ABPI, sometimes just called ABI.
What's involved there?
It's actually quite simple. They use a blood pressure cuff to measure the pressure in your ankles, and then they compare that to the pressure in your arms.
Okay.
Normally, the pressure in your ankles should be about the same or even a little bit higher than in your arms. If it's significantly lower in the ankle, that's a strong sign that blockages in your leg arteries are reducing blood flow.
Interesting. Does it change with age?
Well, the sources note that the ratio usually nudges up slightly as we get older, but it might actually decrease earlier in life for people with risk factors like diabetes or smoking. A low ABI reading is considered a powerful predictor of future cardiovascular problems like heart attack or stroke.
And you mentioned a practical point about compression stockings.
Yes, that was an interesting detail. If the ABI is below a certain point, specifically less than 0.9, doctors might advise against using standard compression stockings because, squeezing the leg could potentially reduce blood flow even more and risk skin damage, especially if you also have diabetes.
Wow, okay. So that simple test has real-world implications. What about tests that give more of a visual, like seeing the arteries?
Right. For more detail, duplex ultrasonography is often the first step. Think of it as a sophisticated ultrasound.
Like the ones used for babies.
Similar technology, but adapted for blood vessels. It uses sound waves to create images of the arteries, and it uses the Doppler effect to measure the speed and direction of blood flow inside them. It gives a dynamic picture. Doctors can see where the narrowings or blockages are and how much they're actually affecting the flow. Adding color to the image, color duplex, makes it even clearer to see the flow patterns. It's fantastic because it's non-invasive and gives a lot of information.
So you can literally see the blockage and how the blood's struggling.
Pretty much, yeah. Then for an even more detailed map, especially to see the whole network of arteries, look for calcified plaques, or maybe check for collateral circulation. Those are tiny extra vessels the body sometimes grows to try and bypass a blockage.
Nature's own detour.
Kind of, yeah. For that level of detail, computerized tomography angiography, or CTA, is often used. This involves getting an injection of a special contrast dye and then using advanced X-rays to create really detailed cross-sectional images of your arteries. It gives the surgeon a precise roadmap before they even make an incision.
Is there an alternative to CTA?
Yes, magnetic resonance angiography, or MRA, is mentioned. It uses magnetic fields and radio waves, not X-rays, but it can provide similar detailed images of the blood vessels. The choice between CTA and MRA often depends on individual patient factors and what the doctors are looking for.
So multiple ways to get that detailed plumbing picture before deciding on the best surgical fix. What about checking the heart itself? Is that always part of the workup? Surgery is stressful on the heart, isn't it?
It definitely can be. So a cardiac evaluation might be necessary. But the sources clarify it's not usually a routine, extensive workup for everyone, especially if your known heart disease is stable and well managed.
When is it strongly recommended then?
It's more likely if your heart function isn't great to begin with. For instance, if you have what's called poor functional capacity, basically, if you get easily winded or can't do much physical activity. The sources mention a threshold, like being unable to manage activity equivalent to about 4 METs, which is sort of like climbing a flight of stairs.
Okay.
It's also advised if you have significant unstable heart problems, things like unstable chest pain, what's called angina, or heart failure that's not well controlled, severe problems with your heart valves, or significant regular heart rhythms. Getting the heart checked in those situations helps make sure it's safe for you to undergo the anesthesia and the stress of the operation.
Right, makes sense. So, okay, this whole preparation phase is really comprehensive, tackling health risks, medication reviews, detailed artery scans, sometimes a heart check.
It really is multifaceted. And, here's what I find really interesting, connecting the dots in these sources. They strongly imply again and again that all these prep steps, especially getting your overall health optimized and those risk factors under control, it doesn't just make the surgery safer, it significantly improves the long-term outcome, how well the repair holds up over time.
So it's an investment in the future success of the surgery.
Exactly. It's about putting your body in the best possible state to heal well, recover strongly, and keep that blood flowing smoothly long after the operation is done.
It makes intuitive sense, doesn't it? A healthier baseline means you're better equipped for the challenge. Okay, let's shift gears slightly to step 2. Based on everything we've just discussed, what are the key things someone should actively avoid or be really careful about in the lead up to the procedure?
Right. Building directly on that prep phase, some definite don'ts or be very carefuls emerge from the sources. And number 1, again, no surprise, smoking.
Avoid smoking completely.
Absolutely. We talked about quitting being vital for long-term health, but stopping smoking well before surgery. It dramatically improves how your wounds heal and seriously cuts down the risk of complications around the time of surgery, things like lung problems, pneumonia, or blood clots. Your doctors will give you a specific timeline, but honestly, the sooner you stop, the better.
So it makes the surgery itself safer, not just the recovery.
Definitely. Another thing to avoid is letting your blood pressure run wild. You really want to work with your doctor to get it well controlled as the surgery date gets closer. Uncontrolled high blood pressure just adds unnecessary risk during the procedure.
And those blood-thinning medications we talked about, avoiding stopping them on your own, right?
Yes, precisely. Those antiplatelet drugs or anticoagulants need very careful management. The sources stress this. Stopping them, changing the dose that has to be done only on the specific instructions of your surgeon and medical team.
Because of that bleeding versus clotting balance?
Exactly. The risk of bleeding during or right after surgery goes up with these meds. So a plan will be made to manage them safely, maybe stopping them a few days before, maybe bridging with a different short-acting medication. It depends. But the key is, it's a carefully managed decision. Never just stop them yourself. The sources explicitly mention dual antiplatelet therapy, potentially increasing bleeding risk, reinforcing why this careful planning is so crucial.
That really highlights the need for crystal clear communication with your doctors about every single pill you take.
Couldn't agree more. Open communication is key. Oh, there was one other small detail, more of a technical point from the sources, related to vein mapping.
What's that?
Sometimes, if the surgeon plans to use one of your own veins for the bypass graft, they'll use ultrasound beforehand to map out a good vein in your leg. The sources mention that during this mapping, they prefer to use only a limited amount of ultrasound gel.
Why is that?
Apparently, it makes it easier to mark the vein location directly on the skin afterward, and maybe reduces discomfort from the gel evaporating and feeling cold. It's not something you as the patient need to worry about avoiding, but it's a little behind-the-scenes detail illustrating the careful techniques used even before the main event.
Interesting peek behind the curtain. And maybe one more thing to avoid that's perhaps less tangible.
Well, yeah, I'd say based on the whole point of creating this roadmap, try to avoid feeling completely overwhelmed, which is easier said than done, I know.
Sure.
But understanding the process, knowing what steps are coming, which is what we're aiming for here, can genuinely help manage anxiety. Feeling informed and prepared can significantly reduce stress in the lead up to a major procedure like this.
That's a fantastic point. Knowledge really is power in these situations.
Yeah.
Okay, let's move forward. Step 3. What can you expect on the day itself, when you're actually admitted to the hospital for the procedure?
Right, admission day. Once you arrive, the focus shifts entirely to getting you ready for the operating room safely and efficiently. The sources describe a pretty structured process, standard for major surgeries.
What happens first? Walk us through it.
It starts with rigorous checks. Patient identification is paramount. Staff will ask your name, date of birth, check your wristband, confirm the exact procedure you're having, and, crucially, confirm the correct side and location on your body for the surgery.
Multiple times.
Yes, expect it to happen multiple times by different people. They use safety checklists throughout this process. It's all about ensuring everything is perfectly aligned before anything else happens, purely for your safety.
Okay, check's done. Then what physically happens to get you prepped?
You'll have monitoring equipment put on, sticky pads on your chest for heart monitoring, a cuff on your arm for blood pressure, a clip on your finger for oxygen levels. These monitors allow the anesthesia and surgical teams to keep a constant eye on your vital signs throughout everything.
And then the anesthesia.
Yes. For an open vascular procedure like this, general anesthesia is the norm. That means you'll be given medication, usually through an intravenous line, that will put you completely asleep. You won't feel any pain or remember the procedure itself. The anesthesia team manages this very carefully.
Are other medications given around this time?
Typically, yes. Preoperative antibiotics are standard. They're given through your intravenous line before the surgery starts to help prevent infection developing at the surgical site later on.
What about tubes or lines? Anything else inserted?
It depends a bit on the specific surgery and your condition, but often, yes. A small, flexible tube called a Foley catheter is usually inserted into your bladder. This allows the team to accurately monitor how much urine your kidneys are making during and after surgery, which is an important indicator of how well your body is doing.
Okay.
Sometimes, depending on the extent of the surgery, especially if it involves the abdomen, a tube might be placed through your nose or mouth down into your stomach, a nasogastric or orogastric tube. These are usually temporary, just to keep your stomach empty and prevent nausea.
And then, just before the actual surgery begins, what happens in the operating room?
Right before the start, the area of your body where the incision will be made, your leg, groin, maybe abdomen will be carefully prepped. This means cleaning the skin very thoroughly with an antiseptic solution to kill germs. Then, sterile cloths or drapes will be placed all around the area, leaving only the specific surgical site exposed. This creates a sterile field, a germ-free zone, to minimize infection risk.
It sounds like a very precise, deliberate setup. Is there one final check before the surgeon actually starts?
Yes, absolutely. This is critical. The sources emphasize the timeout. The entire surgical team, surgeons, anesthesiologists, nurses, pauses just before the incision. Everyone stops. They go through a final checklist out loud, confirming again. Correct patient, correct procedure, correct site, necessary equipment available, any potential concerns addressed.
Like a final huddle.
Exactly like that. And this might even happen more than once, maybe before anesthesia starts, and definitely right before the first cut. It's a non-negotiable safety step.
It really underscores the intense focus on safety. Okay, let's move into the operating room, metaphorically speaking. Step 4. What actually happens during the open vascular procedure itself? What is the surgeon doing in there?
Okay, so during the operation, the surgeon's main goal is to restore good blood flow past that blocked or narrowed artery section. It's usually about bypassing the blockage or sometimes repairing the artery directly.
How do they get started?
It begins with the incision. The surgeon makes a cut through the skin and underlying tissues to get access to the artery that needs fixing. The location and length of this incision depend entirely on where the problem artery is located. Could be in the abdomen for the big vessels like the aorta or iliac arteries, or in the groin or down the leg for arteries like the femoral or popliteal. The sources mention things like a vertical midline incision in the abdomen for those higher up vessels.
Once they've made the incision, what's the next step?
Careful dissection. The surgeon meticulously separates layers of tissue to identify and expose the target artery. They also need to identify and protect nearby structures, nerves, veins, other organs. For example, if they're working in the abdomen, the sources describe needing to carefully move parts of the bowel aside or identify the ureter, the tube carrying urine from the kidney, to make sure it's not injured. It requires intricate anatomical knowledge and very precise technique.
Sounds incredibly delicate.
It really is. Once the segment of artery they need to work on is clearly exposed, the next crucial step is to control the blood flow. They need a relatively blood-free area to work.
How do they stop the blood flow temporarily?
They use special surgical tools called vascular clamps. These are gently placed on the healthy artery above the blockage and below the blockage. This isolates the disease section, stopping blood from flowing through it while they perform the repair or bypass. Getting those clamps on safely also requires careful dissection around the vessel.
Okay, clamps are on, blood flow stopped in that section. What happens then? How do they actually fix the artery?
There are a few possibilities based on the sources. Sometimes, if it's a very localized problem, they might open the artery, clean out the plaque, that's called an endarterectomy. Or if there was an injury, they might be able to sew the ends of the artery back together, an end-to-end anastomosis, but only if there's no tension.
But more often it's a bypass for peripheral arterial disease, right?
Yes, for significant blockages causing symptoms, a bypass is very common. This means creating a new channel for the blood to flow through, completely avoiding the blocked section.
How do they build that new channel?
They use a graft. This is essentially a tube that they sew into the healthy artery above the blockage and the healthy artery below the blockage. Blood then flows through this new graft, bypassing the diseased part entirely.
What are these grafts made of?
The sources mention two main types. One is an autograft, which means using tissue from the patient's own body. Most commonly, this is a vein, often the saphenous vein taken from the leg, assuming it's healthy and suitable. The other type is a prosthetic graft, which is made from special, durable synthetic materials like Dacron or PTFE, polytetrafluoroethylene.
Is one type generally preferred?
Often, using the patient's own vein is preferred if possible. It's living tissue, potentially more resistant to infection, and might last longer in some situations. However, sometimes a suitable vein isn't available, or it's too small, or the bypass needs to be very long. In those cases, or sometimes for very large arteries, a synthetic graft is used. The sources do note a consideration. If the surgery involved opening the bowel for access, surgeons might try to avoid using a synthetic graft right then because of a higher risk of infection settling on the foreign material.
Okay, so they carefully choose the graft material and sew it in place. Anything else before they finish that part?
Yes, before they fully complete the connections or anastomosis and release the clamps, they'll often flush the graft and the artery. This helps wash out any tiny clots or debris that might have formed while the clamps were on, ensuring a clear path when blood flow is restored.
Makes sense. Once the bypass is done, what about bleeding? That seems critical to manage.
Absolutely. Hemostasis controlling bleeding is vital. The surgeon meticulously inspects the suture lines, where the graft was sewn to the artery, checking for any leaks. Small amounts of oozing from needle holes are common and can often be controlled with topical agents, special materials like Surgicel, Gelfoam, or thrombin applied directly to the area to help the blood clot.
And the final step inside.
Once the vascular repair or bypass is complete, blood flow is restored by removing the clamps, and the surgeon confirms everything looks good, with good flow through the graft and no significant bleeding. A key point mentioned in the sources is ensuring the graft lies naturally, without any kinks or tension, as that's important for it to stay open long term.
Okay, then they close the main incision.
Exactly. Once everything inside is satisfactory, the main surgical incision is closed. This is usually done in layers, sewing the deeper tissues together first, then closing the skin, often with sutures or surgical staples.
Wow. A very intricate process to reroute that vital blood supply. Okay, let's fast forward. Surgery's over. Step 5. What can you expect immediately after the procedure during that initial recovery period in the hospital?
Right after surgery, you'll usually be moved to a recovery area. Often it's called the post-anesthesia care unit, or PACU. Sometimes, depending on the complexity of the surgery, you might go to an intensive care unit or a specialized vascular unit.
What's the main focus in this immediate post-op phase?
Close monitoring, that's the absolute priority. Nurses and doctors will be watching your vital signs constantly: heart rate, blood pressure, breathing rate, oxygen levels as you wake up from the anesthesia. They'll also be paying very close attention to the operated leg, checking the pulses, the color, the temperature, the sensation to make sure the blood flow through the new bypass is good and stable.
Pain is obviously expected after open surgery like this.
Oh, yes, definitely. Open surgery involves cutting through tissues, so there will be pain at the incision site. Managing that pain effectively is crucial right from the start. You'll be given pain medication, often through your intravenous line initially, maybe later as pills. Keeping your pain controlled is important not just for comfort, but so you can breathe deeply, cough if needed, and eventually start moving around.
Will those tubes and lines that were put in before or during surgery still be there?
Yes, most likely, at least for a while. The Foley catheter in your bladder, the intravenous lines for fluids and meds, maybe an oxygen mask or nasal prongs, they'll likely remain in place during the first hours or day or so. They're removed gradually as you recover and your condition stabilizes. If you had a nasogastric tube, that might stay in for a bit too.
And the surgical wound itself, what about that?
The incision will be covered with a sterile dressing. The nursing staff will monitor the dressing for any excessive bleeding or drainage. They'll follow the surgeon's instructions for wound care. While the sources don't detail specific dressing change schedules for this exact surgery, they do mention, in the context of other vascular procedures, that sometimes ultrasound might be used before discharge to check for things like hematomas, collections of blood under the skin near access sites like the groin. It just shows that careful wound assessment is part of the recovery process.
What happens with the blood thinners after surgery? Are they restarted right away?
Managing those antiplatelet or anticoagulant medications is a really important part of post-operative care. Your doctors will decide when and how to restart them based on the surgery you had and your bleeding risk versus your clotting risk. The sources talk about the importance of post-operative antiplatelet therapy to help keep the bypass graft open. Sometimes other medications like low molecular weight heparin might be used for a period, especially if the risk of clotting is high.
And what about that testing for clotting disorders you mentioned earlier?
Right, particularly if the surgery was done for a very sudden severe blockage, what's called acute limb ischemia. The sources mention that doctors might do blood tests after you're stable to see if you have an underlying condition that makes your blood clot too easily. Finding something like that could influence the long-term plan for blood thinning medication to prevent future problems.
You also mentioned something called reperfusion syndrome as a risk after restoring blood flow to a severely starved limb.
Yes, that's a potential issue again, mainly if the surgery was for acute limb ischemia. When blood flow suddenly returns to tissues that have been deprived of oxygen for a while, damaged muscle cells can release substances into the bloodstream.
What kind of substances?
Things like potassium, acids, and a muscle protein called myoglobin. These can sometimes overwhelm the body. Myoglobin, for example, can be tough on the kidneys and might cause the urine to turn dark or reddish-brown. In severe cases, these substances entering the circulation can affect the heart, potentially causing arrhythmias or impacting heart function.
So the medical team would be watching very closely for any signs of that.
Absolutely. They'd be monitoring kidney function with blood tests, watching urine output and color, and keeping an eye on your heart rhythm. It's a known potential complication in those specific circumstances.
What about getting up and moving? How soon does that happen after open leg surgery?
The specific timing will depend on your surgery, your overall condition, and your surgeon's preference. But generally speaking, early mobility is encouraged once it's safe. Getting out of bed, even just to a chair initially, and then starting to walk, helps prevent complications like blood clots forming in the deep veins of the legs, DVTs, deep vein thrombosis. It also helps your lungs stay clear. Of course, this has to be balanced with pain control and protecting the healing incision. Your physical therapist and nursing team will guide you on this.
Okay, so the immediate post-op period is all about close monitoring, pain control, managing fluids and meds, watching the wound, and starting to move when it's safe. Let's move on to step 6. What happens after you're discharged? What should you expect and what should you do when you get home?
Right, going home is a big milestone, but it's really a transition, not an endpoint. The recovery continues, and now you're taking a more active role in your own care.
What's top priority once you're home?
Follow-up appointments. These are absolutely crucial. You'll have appointments scheduled with your surgeon, maybe your primary care doctor too. They need to see you to check how you're healing, how the incision looks, assess your blood flow, and make sure your overall recovery is on track. Don't miss these appointments.
And the medications. Still vital.
More than ever. Medication adherence is critical. You have to keep taking all your prescribed medications exactly as directed. That means the antiplatelets, the statins for cholesterol, any blood pressure pills, diabetes medications, whatever your doctor has prescribed. The sources really emphasize that sticking to these medications long-term is key to preventing future blockages and keeping that bypass working well.
What about caring for the incision itself at home?
Your discharge instructions will include specific guidance on wound care. This might involve keeping it clean and dry, maybe changing dressings for a period, and importantly, knowing what signs of infection or problems to look for. Following these instructions carefully helps prevent complications and promotes good healing.
And getting back to activity. How quickly can you resume normal life?
It needs to be gradual. Your doctor will give you specific advice on activity restrictions and when you can start increasing what you do. It's important not to overdo it early on, but gentle activity, especially walking, is usually encouraged. Walking helps improve circulation and build stamina. Listen to your body, but follow your doctor's timeline for returning to things like driving, work, or more strenuous exercise.
And staying alert for problems.
Yes, being vigilant for any warning signs is crucial during this home recovery phase. You need to know what to look out for, which ties directly into our next step, Step 7. Knowing potential red flags and acting quickly if they appear is a key part of managing your recovery at home.
Got it. Anything else key for that period right after discharge?
Really, it's about reinforcing those healthy lifestyle habits we talked about way back in the preparation phase. Sticking to a heart-healthy diet, managing your weight, and absolutely positively staying smoke-free. These aren't just short-term fixes, they are lifelong commitments that are vital for your ongoing vascular health and the long-term success of your surgery.
So the time at home is about physical healing, combined with actively managing those risk factors for the long haul.
Exactly. It's an active partnership between you and your body, supported by your medical team, to get the best possible long-term result.
Okay, that leads us perfectly into step 7. Let's talk specifics about those warning signs. What potential complications should someone be watching for after this type of open vascular surgery, and when should they absolutely seek medical help?
Knowing the warning signs is so important because catching a potential complication early can make a huge difference in treatment and outcome. The sources mention several things to be vigilant about.
Let's start with the incision site itself. What are the red flags there?
You need to watch for signs of significant bleeding or swelling. A little bruising is normal, but if the incision starts bleeding actively, or if you develop significant painful swelling around it, especially if the incision was in the groin area, that could indicate a hematoma, a collection of blood under the skin. The sources specifically mention groin swelling as a known potential issue after vascular access.
And infection. What does that look like?
Signs of a wound infection would be increasing redness around the incision, the area feeling unusually warm to the touch, worsening swelling or pain, or any drainage from the wound, especially if it's thick, cloudy, or foul-smelling, what you might think of as pus. A fever could also be a sign.
What about pain in the leg itself, not just at the incision?
If you develop new or significantly worsening pain in the operated leg, particularly if it's severe and feels different from the soreness of the healing incision, that's a concern. It could potentially signal a problem with blood flow or another issue, and it needs checking out promptly.
Are there changes in how the leg looks or feels that should raise alarm?
Yes, definitely. Watch for signs that the blood flow might be compromised again. Is the operated leg or foot feeling unusually cold compared to the other side? Are you experiencing new numbness or tingling sensations? And look closely at the color if the skin becomes very pale or takes on a dusky bluish tinge. Those are urgent warning signs suggesting poor circulation.
We touched on reperfusion syndrome earlier with the potential for dark urine. Is that something to watch for at home too?
It's less common to develop severe symptoms at home as it usually manifests earlier. But yes, if you notice your urine becoming consistently dark, like tea or cola colored, that could still indicate muscle breakdown affecting the kidneys and warrants a call to your doctor. And certainly any new unexpected symptoms related to your heart, like palpitations or severe shortness of breath, should be treated as an emergency.
What if the original symptoms, the reason you had the surgery in the first place, seem to come back, like the leg pain when walking?
That is a very important warning sign. If you start experiencing the return of claudication, the characteristic pain or cramping in your calf or thigh when you walk, or if you develop pain in the leg even when you're resting, unfortunately, that could mean the bypass graft or the repaired artery has become blocked or narrowed again. This requires immediate medical evaluation.
So it's a combination of looking at the wound, paying attention to pain, checking the limb's temperature, color, and sensation, and being aware of any return of the old symptoms or new systemic issues.
Exactly. And the bottom line, the most crucial takeaway here is any sudden, severe, or rapidly worsening change in your operated leg or in your overall condition is a reason to contact your doctor or seek emergency medical attention immediately. Don't wait and see. Prompt action is key.
That's very clear. Being informed and acting fast is critical. Okay, let's shift focus to the longer term. Step 8. After a successful surgery and recovery, what can you do specifically to try and avoid the peripheral arterial disease from coming back or getting worse?
This is absolutely central to long-term success. Preventing recurrence or progression of the disease in other arteries hinges almost entirely on managing those underlying causes and risk factors we keep coming back to. Remember, the surgery fixed a specific plumbing problem, but the underlying tendency for plaque buildup often remains.
So we're circling right back to that preparation phase advice, but making it permanent.
Precisely. It's about taking those preparation strategies and making them a sustained, lifelong commitment. Lifelong risk factor control is, without doubt, the most critical step. It's the bedrock of maintaining the benefits of the surgery and protecting your entire vascular system.
Okay, lay out the absolute non-negotiables again.
Number 1, with a bullet. Strict, complete, permanent smoking cessation. No vaping, no cigars, no tobacco in any form. The sources are absolutely clear. Smoking is a primary driver of this disease progressing. If you continue to smoke, the risk of your bypass failing or developing new blockages elsewhere skyrockets.
Heard loud and clear. Still number one. What else?
Keep managing that blood pressure. Consistently keeping it within your target range reduces the ongoing stress on your artery walls. This means regular checks and faithfully taking your prescribed medications. Same goes for cholesterol. Ongoing management, usually with statin therapy, is crucial to keep those plaque-building fats under control.
And for people managing diabetes alongside this?
If you have diabetes, maintaining excellent blood sugar control is paramount. Diabetes accelerates blood vessel damage, so keeping your sugar levels stable is vital for preventing further progression of peripheral arterial disease and lowering complication risks.
Lifestyle factors still play a role long-term.
Immensely. A heart-healthy diet, low in saturated fat, processed foods, excess sugar remains important for overall cardiovascular health. And regular exercise, especially that structured walking program, continues to be a cornerstone. It helps maintain good circulation, improves how your muscles use oxygen, and contributes to overall well-being.
And medication adherence, still vital.
Absolutely non-negotiable. Consistently taking all your prescribed medications, the antiplatelets, the statins, blood pressure meds, diabetes meds is essential. They're working behind the scenes every day to protect your arteries and prevent clots.
You mentioned earlier that sometimes doctors test for underlying clotting disorders.
Yeah,
If something like that is found, how does it impact long-term prevention?
that's a good point. If those tests reveal a specific hypercoagulable state, a condition making your blood more prone to clotting, like certain antibody syndromes or genetic factors, then specific long-term treatment might be needed. This could involve different types or combinations of blood thinners, maybe lifelong, or specific supplements like folate for certain conditions. It becomes a more personalized prevention strategy based on that identified risk.
And keeping the medical team in the loop.
Regular follow-up is key. Maintaining your scheduled appointments with your vascular specialist and primary care doctor allows them to monitor your condition, track your risk factors, adjust medications as needed, and catch any potential issues early. Think of it as ongoing preventative maintenance for your vascular system.
So preventing recurrence really boils down to integrating the surgical fix with a lifelong, proactive commitment to managing your overall health and specific risk factors.
That's it exactly. It's acknowledging that peripheral arterial disease is typically a chronic condition that requires continuous attention and active management to maintain good blood flow and quality of life.
Which brings us very smoothly to our final step, step 9. Even after a successful open procedure, what does long-term conservative management of peripheral arterial disease look like?
This is such an important point to finish on because, yes, the surgery can be life-changing, restoring blood flow and relieving symptoms. But as we've established, peripheral arterial disease is usually systemic. It affects arteries elsewhere too. So even with a successful bypass, ongoing conservative management remains absolutely vital for the rest of your life.
Is this essentially the same as the prevention strategies we just discussed?
There's a huge overlap, yes. The core principles are the same. That aggressive, lifelong management of risk factors, no smoking, controlling blood pressure, managing cholesterol with statins, excellent diabetes control that remains the absolute foundation of long-term care. It's not just about protecting the surgery site, it's about slowing down the disease everywhere else.
And exercise continues to be important.
Critically important. That structured exercise program, usually involving walking, is still highly recommended. Even years after surgery, regular walking helps maintain good circulation, improves walking distance if you still have any limitations, and contributes significantly to overall cardiovascular health and quality of life. It encourages the body to maintain or even develop those helpful collateral vessels.
What about the medication side of long-term management?
Ongoing medical therapy is a key pillar. This almost always includes continuing an antiplatelet medication daily, like aspirin or clopidogrel to prevent clots. You'll typically stay on statin therapy indefinitely for cholesterol. And of course, continuing any necessary medications for blood pressure or diabetes remains crucial. These medications are your long-term partners in keeping your arteries as healthy as possible.
If someone had severe problems before surgery, like non-healing sores or ulcers, is there specific long-term care needed related to that?
Yes, definitely. If your peripheral arterial disease was severe enough to cause critical limb ischemia, non-healing wounds, or gangrene, then ongoing, meticulous foot care is essential long after the surgery has restored blood flow. This is especially vital if you have diabetes or nerve damage causing reduced sensation in your feet, because you might not notice small injuries that could become serious. Regular self-checks, proper footwear, and professional foot care are crucial to prevent recurrence.
We talked earlier about compression stockings being potentially problematic with low blood flow. How does compression therapy fit into the long-term picture for someone with peripheral arterial disease, maybe if they also have vein issues?
Right, that's a really nuanced area the sources touch upon. Compression therapy is standard for managing venous problems like varicose veins or swelling. But, as we discussed, applying significant compression to a leg with compromised arterial blood flow can be dangerous. It could potentially worsen the arterial circulation.
So it's not routinely used if you have peripheral arterial disease.
Not standard compression. Generally, no, especially if the arterial disease is significant. The sources suggest that if someone has both venous issues and arterial disease, modified, lighter compression might be considered, but only after a very careful assessment of the arterial flow. They mention specific pressure thresholds, needing ankle pressures above 60 millimeters of mercury, toe pressures above 30, or an ABI above 0.6 before even considering modified compression safely.
And if the pressures are lower than that?
If the arterial pressures are below those levels, the sources indicate that sustained compression should generally be avoided. In such cases, addressing the arterial insufficiency first, perhaps with further revascularization if possible, might be necessary before any form of compression could be safely used.
That really underscores how complex managing vascular health can be, needing careful assessment of both arteries and veins.
It absolutely does. It highlights that long-term management of peripheral arterial disease requires ongoing informed care integrating risk factor control, medication, exercise, specific preventative measures like foot care, and being very mindful of how treatments for other conditions interact. Fundamentally, it's about recognizing this is a chronic condition requiring a continuous partnership with your medical team for the best long-term health.
Wow. That really was a comprehensive journey, a true deep dive through preparing for, undergoing, and recovering from open vascular surgery for peripheral arterial disease. We've essentially built that roadmap we aim for.
We covered a lot of ground, from optimizing health beforehand, right through the hospital stay, surgery recovery, going home, watching for warnings, and crucially, those long-term steps.
You know, what really stands out to me from weaving through all this information is the incredible symmetry between step 1, the preparation, and steps 8 and 9, the long-term prevention and management.
That's true.
It just hammers home that the patient's own actions, managing smoking, diet, exercise, taking those meds religiously, they aren't just nice-to-haves. They seem absolutely fundamental, interwoven with the surgical success itself. Like you said, the surgery fixes the immediate plumbing issue, but it's the lifestyle and the medication that keep the whole system protected long-term.
I couldn't agree more. It really highlights the patient as an active participant, a co-manager in their own vascular health journey. And, if we connect this back to the bigger picture, thinking about how dynamic blood vessels actually are. They're not just passive pipes. They respond to flow, to pressure, to the biochemical environment. Some sources hint at this capacity for remodeling.
Right.
It makes you wonder, doesn't it? Given that adaptability, how much can that consistent long-term dedication to lifestyle changes and medical management actually influence the remaining vascular system over time? Could it perhaps help the body compensate or even positively remodel things, enhancing the benefits of the surgery well beyond just preventing recurrence?
That's a really powerful thought. Can taking that sustained control potentially do more than just halt the decline? Could it actively foster better vascular health throughout the body in the long run? Definitely something significant to ponder, whether you're navigating this journey yourself or just learning more about this incredible biological system.
Indeed. Food for thought.
Well, that's all the time we have for this deep dive. We genuinely hope this roadmap provides clarity, reduces uncertainty, and helps you feel more informed and prepared. Thanks for joining us.